Hi, and welcome back to the NCS podcast. This is Lauren Kaufman. I'm a neurointensivist at Temple University in Philadelphia. The views expressed on the NCS podcast are solely those of the hosts and guests and do not necessarily reflect the opinions or official positions of the Neurocritical Care Society. Today, I'd like to welcome onto the podcast authors from a recent Currents article, Seizure Code Strategy, Improving Treatment Times and Clinical Outcomes in Patients with Urgent Epileptic Seizures. So I'd like to welcome two authors. We have Cleo Rubinos, who's a neurointensivist and epileptologist at UNC, and Camilo Espinosa-Jovel, who is an epileptologist at Hospital de Kennedy in Bogota. Welcome, both of you. So before we kind of talk about what your focus in this article is and how it's changing an approach to caring for patients with seizures, I'd like to just hear a little bit about how you guys either met or started to collaborate, being that you practice in different continents.
Yeah, so in my case, I have been following Cleo's work for a while, especially in the field of status epilepticus and acute symptomatic seizures. And so I was already familiar with her work before I met her. And last year, after we published our paper on the experience of the Seizure Code Strategy, she contacted me and we started some collaboration projects. And then she gave me the opportunity to share our experience with the Seizure Code in the AAN conference in San Diego. And since then, we have had like a closer contact and we have shared some experiences in other meetings.
Awesome. Thank you so much. So before we kind of talk about the whole protocol you've developed it and why you developed it, I'd just like to hear a little bit about from you guys what this concept of an urgent epileptic seizure is, because for most of us, we know what seizures are, we know what status is, but this might be a newer concept or term for some people.
So the concept of urgent epileptic seizure is a concept that has been described in recent years. The main goal of the concept is we're trying to be more inclusive in the treatment of emergency seizure disorders. And we're trying to encompass different clinical scenarios because there is a misconception that the only scenario that we have to treat in emergency settings is a status epilepticus. But we know that there are other circumstances such as seizure cluster and high-risk seizure that we know that those scenarios are also dangerous. And we are trying to move toward a more preventive treatment rather than a reactive treatment, because we know that once the status epilepticus is established, in many cases, treatment is delayed. So we are trying to move toward a more preventive scenario. And for that reason, we are trying to include all the conditions that eventually could require any kind of treatment, such as seizure cluster and high-risk seizure. So that's like the main aim and the main goal of describing the emergency seizure disorders under the concept of urgent epileptic seizure.
Thank you. And, talking about the importance of treating these seizures, a lot of the hospitals, at least in the US, as far as I'm aware, like it's pretty common for us to have a protocol or a pathway for how we manage these patients. But could you maybe describe some barriers to how that might be implemented in a limited resource setting?
Lauren, I would like to add something to what Camilo has previously answered. That Camilo and we worked together at the recent Colombian International League Against Epilepsy meeting in Cali about a month ago. And I was discussing with him the proposal of talking about the continuum of a status epilepticus that doesn't start when you already are entering the T1 stage as a functional definition for status epilepticus, but actually can be before that. And before that is these urgent or high-risk seizures that might be at one point impending into developing into status epilepticus, and how we probably have to start thinking about implementation science for even those high risk to prevent them to continue to more refractory seizures that are more challenging to control. So Camilo and I were thinking about doing another paper of collaboration discussing this new definition for the awareness of that each seizure is not the same, and some of them might have to be treated more urgently than other ones. And, and regardless, in your question about the pathway and protocols, so just to the same concept of status epilepticus continuum or the continuum of status epilepticus, the protocols and pathway for treatment of these seizures start even at pre-hospital treatment. We have great data. The Rampart study used EMS for benzodiazepine administration to stop status epilepticus, and that's one of the biggest implementation. How do we actually give medication to the patients before the hospital? And it's something that we don't really have in lower to middle income countries because there's not a lot of education for the caregivers. There's not also an EMS or a 911 or an emergency service line in most of the lower to middle income countries. If you read papers of status epilepticus for lower to middle income countries, the patients, up to 99% of them, are actually brought to the hospital by the family members. And when you read the literature coming from Africa, it can take up to more than 24 hours to come to the hospital. So that is one of the biggest, lack of implementations. And then is the activation of disease status epilepticus in the ER, as you have to give medications that we know are really great first-line medications, as for example, IV lorazepam, which is not widely available in Latin America. In Latin America, they use a lot more of diazepam, which is also a great drug, but then it's challenging in terms of the administration because we don't have intranasal diazepam. It's a new drug as well, and this doesn't exist in Latin America. So just to give you a bit of example that even though with the first and earliest stages that we know that we have to control this fire right away, we don't have the means in lower to middle income countries, and that is one of the biggest, I guess, like the first challenges. We can continue with other challenges as like second and third line availabilities, as for example, IV levetiracetam. We don't have that available in most of the hospitals in Peru. I'm working right now in establishing ICU EEG capacity building in a hospital in Peru, and also establishing a status epilepticus protocol in the same hospital. And when we're discussing about the protocol, the lack of not having IV levetiracetam, one of the second lines that has been very well studied, is also one of the challenges that we can have in these countries. And then to go to a third line, one of the commonalities is that, for example, midazolam is not always available. Propofol is, midazolam is not, and pentobarbital is one of the biggest agent also is not available. So some hospital has to go to isoflurane. So you can see in each of the stages of the status epilepticus continuum, there are a lot of lack of capacity, there's no implementations of the needs. There's not availability or accessibility of the medications as well that have been mostly studied and for what the guidelines recommend us to use.
Thank you. And Camilo, was there a particular experience or something that really motivated you to work on this?
Yeah, maybe the most relevant motivation was the fact that we realized that several lines of evidence have shown that the most relevant factor that impacts the prognosis in these patients is timely treatment, is how fast can you stop seizures. And there is robust evidence, and we have clear evidence showing that. But despite the evidence, we realize that treatment times are quite prolonged in many contexts. Obviously, it's more common in low-income populations, but this was a huge problem, and we realized that treatment was administered with a significant delay in many cases. And we were trying to raise awareness on the importance of timely treatment. So that was one of the main motivation. And the second one was the fact that it wasn't just a matter of providing a delayed treatment, but it also was a matter of providing a treatment with a high variability. So in many cases, we were treating these patients with low doses. We were not following institutional protocols, and this was a mess, actually. So the protocol, or the main goal of the protocol, was to provide a well-organized and a timely treatment for every patient with an emergency seizure disorders. And following the line of what Cleo has just mentioned, I have to add that the main barriers that we found in our context was, as Cleo mentioned, the pre-hospital infrastructure is scarce in many countries. We have a huge pre-hospital treatment gap in these patients. We have also an educational gap because in many cases, many doctors tend to be more flexible with the treatment, especially with patients with seizure clusters, with high-risk seizures, or patients with non-convulsive seizures. So in many cases, people don't have a sense of emergency. And that is reflected by the fact that in many circumstances, we are offering a delayed treatment even within the hospital, not only in the pre-hospital setting, but also when the patient has arrived to the hospital. So those were like the main motivations for creating this protocol and trying to raise awareness on the importance of timely treatment, because we realize that in this context, every minute counts, and we need to act fast in order to prevent the complications of these conditions.
Thank you. Now, do you think you could tell us a little bit about the protocol itself, how long it took to develop it, and then what implementing it looked like?
Yeah, so it was a long work. I mean, maybe 1 year, 1.5 years. We implemented the protocol in a sequential way. So the first step was to create the protocol itself, which is basically a literature review. We had the opportunity of counting with the guidance of some experts, and we were trying to following the experience of vascular neurology with the stroke code. And we were trying to follow also the experience of other groups, especially in Spain, where they were the first that created this concept of seizure code. So the first step was to create a protocol, and we tried to adapt those experiences into our socio-demographic context. The next step was to ensure the availability of all the intravenous anti-seizure medications in our country. And that was a huge challenge because before the seizure code, we were using the medication that we had, but it wasn't necessarily the medication that we want for the patient, depending on the clinical context. So that was a critical step. We were trying to ensure the availability of all the anti-seizure medications in our country. And then the next step was to train all the personnel. We tried to create a sense of teamwork. So we included not only neurologists, but also emergency medicine doctors, nursing staff, internal medicine, ICU doctors, and we tried to create this sense of teamwork following the experience of vascular neurology. And then the last step was to implement the seizure code, and the flow chart of a seizure code is pretty simple. So every patient with a suspected epileptic event in the emergency department is evaluated by the first responder, that in our case is the emergency doctor, and then they decide if the patient meets the activation criteria, and then they activate the code, and the seizure code team responds. And then the first step is to classify the patient depending on the clinical context. So we have, for instance, low-risk seizures, high-risk seizures, seizure clusters, status epilepticus, or non-epileptic paroxysmal events. And depending on the clinical context, we try to follow an algorithm and a flow chart, and we try to provide a specific treatment depending on the context. So that's like a quick summary of how the seizure code worked and how did we implement the protocol.
I mean, you just mentioned, collaboration with a lot of different kinds of providers. I mean, could you just go a little further to explain it? I assume, it involves pharmacy, nursing, people working in the emergency room. Did you involve the pre-hospital infrastructure at any point?
Yeah, currently our seizure code is just focused on hospital treatment, not in the pre-hospital scenario, because there are several variables that we cannot control. So we're focused on providing a fast or a quick treatment within the hospital. And regarding the people who is involved, actually the most relevant role in our seizure code relies on emergency doctors and nursing staff. Neurology offers like a secondary role and guidance on the diagnosis and on the treatment approaches, but the most relevant role relies on emergency doctors, who are the first responders, and they are playing a critical role in in the whole process, but it also involved, as I mentioned before, nursing, emergency doctors, neurologists, internal medicine doctors, ICU doctors, if available. So it's like a teamwork, and we try to follow the experience of vascular neurology. So that's a really nice thing, because once the protocol is established, everyone knows what to do, and everyone knows the protocol, and everyone knows the recommendations. So we were able to standardize the intervention, and it worked. It really worked.
Were there any challenges along the way or things that you learned or had to adapt to that you weren't expecting?
Yeah, actually, it is a relatively simple intervention that is based mainly on education and teamwork. So the main challenges were associated with trying to reduce that educational gap. So the training sessions were, we had a lot of training sessions. We were focused on emergency medicine doctors and nursing staff. But maybe the main challenges were associated with the educational gap. We were trying to raise awareness on the importance of timely treatment. And then the second challenge that we had was the fact that we don't have a continuous availability of anti-seizure medication. So we have like an intermittent supply of medications, and that's also a challenge that has been like improving with the time.
Thank you. And, you've been able to implement this, run it, it seems like pretty effectively because you published some of the results. Maybe you could just share with the listeners some of the results that you found since enacting this pathway.
Yeah, so we were focused, or the first part of this study was focused on treatment times and hospital outcomes. So we measured many times. So we measured, for instance, time from seizure onset to hospital arrival, time from hospital arrival to seizure code activation, time from seizure code activation to seizure code team response, and time to the first and the second line treatments. So our goal was to demonstrate that a relatively simple strategy that was based on education and teamwork was effective for reducing treatment times and hospital outcomes. So regarding treatment times, we were able to show that, for instance, the time to the first benzodiazepine decreased from a median of around 100 minutes to 20 minutes with a relatively simple strategy, which was very basic. It was just a matter of creating a protocol and following the recommendations and creating a teamwork. And the time to the first anti-seizure medication decreased from a median of 150 minutes to 40 minutes or something like that. So those were like the main results regarding treatment times. And then regarding hospital outcomes, we were able to show that this strategy decreases the hospital stay, reduces the inappropriate use of benzodiazepines, which was a relevant problem before the implementation of the seizure code. This strategy was able to reduce the in-hospital seizure recurrence as well as the in-hospital mortality. So those were like the main results that we found in our experience, and we compared the variables that we measured before and after the implementation of the seizure code, and we were focused on treatment times and hospital outcomes.
Those are extremely huge improvements in terms of time to administration of medications, because we know, time is brain, just like in seizures. Even we tend to think more so in stroke, but it's the same for seizures. So with such an effective protocol you've developed, have you been able to collaborate with other groups and within Latin America to try and implement this there as well?
Yeah, actually, we're very proud that the protocol is being used more and more, not only here in Colombia, but also in some other countries in Latin America. So there are some really nice experiences in Mexico, in Argentina, in Chile, and they're making a huge effort to implement the protocol in their institutions because they realize that this is a very simple strategy that produces a significant effect and a significant impact on the prognosis of these patients, especially within the context of a low-income population.
Thank you. So I'd like to ask Cleo your thoughts on if you think there's any way we should think about applying this protocol or educational initiative to our own practices here within the US.
Yes, no, thank you for that great question, Lauren. I think we should definitely, each of us, look at our own data institution and see how what we're doing with following the guidelines of seizure medication in terms of the time when it's administered from the onset of the seizure, and also about the dosing of the seizure medication that we're given. Because those are two things that we also, I'm sure that if we look into our institutions, we're not really fulfilling with the guidelines. And I think I definitely kudos Camilo what he has done, an improvement in outcomes in his center, and something that we should definitely follow here in the United States, as have been following other countries. To be as a personal example, when I joined UNC, there was not a protocol or status epilepticus order set, so we implemented one, and we have also started with education in the neurology department and the emergency department. And with that, those two establishments of protocol and order set implementation and education, we also have seen that after the first cycle of education, that we are now following the guidelines for the time administration of benzodiazepine. Now our mean is of 17 minutes, which is less than 20 minutes, which is what expected. Before we were like between 40 to 60 minutes. And also we are achieving better dosing of levetiracetam as a first line medication that we were not achieving before. We'll still be short with the amount necessary for benzodiazepine, but noticing that we are expanding our education to other ERs because our data pool was from UNC Health, and our first cycle of intervention was only UNC Medical Center. So now what we are doing with a committee of health equity and community partnership is educating other UNC health centers about the implementation of this protocol and order set in the ER, as Camilo has said, so we can achieve globally in UNC Health, which is lots of different institutions within North Carolina, into treating these patients more optimal treating these patients with time and doses. And again, I want to ask each of the listeners to look at their own data and see from the onset of the seizure to the first benzodiazepine timing given, or for the from the door to needle for first benzodiazepine or first line seizure medication if the patient was already given benzodiazepine at EMS outside hospital, how long are we taking? And you will be surprised that we are taking a lot longer, and we don't recognize this as an emergency as it should be. As you have said, with ischemic stroke, the time is brain, and we do fulfill metrics in terms of timing of the Nectaplace or Alteplase medication.
So would either of you have advice for someone that is interested in, establishing this within their own institution?
Yeah, I would definitely advise it, and then invite them to reach out to us as how we started and how we did our team and our champions. Champions has to be in the pharmacy, has to be in the neurology, has to be in epilepsy group, in neurocritical care, and in emergency. And definitely encourage people to do it because it's we talk a lot about preventing secondary brain injuries, right? Because that's the solely of what we do, because we cannot go and prevent the primary brain injuries because we're not there in the moment. Of course, I don't want to say that primary care is not important. That's the most important thing, more than anything. But once the injury has happened, our biggest as a neurologist is, or critical care physicians, is to treat secondary brain injury. And that's the best way that we can do, by activating emergency codes for this neurological emergency, as the status epilepticus or high-risk seizures are a neurological emergency as well. So definitely encourage everybody, and then more than happy to help and share my experience. I think that epileptologists now, they are more and more aware and active into trying to bring the awareness of the treatment for high-risk seizures and status epilepticus. As a matter of fact, in the American Epilepsy Society this year, there's going to be a session about implementation science, moving the needle in epilepsy care, which is going to talk about all of these, issues and all of these clinical gaps and how we can actually do better for our patients.
Thank you, Cleo. Camilo, any last words of advice for people that might be practicing in a resource-limited setting as to how they can improve the care for their patients with seizures?
Yeah, I would like to add to what Cleo mentioned, that the problem of delayed treatment, the problem of using low doses, of not following protocols is not exclusive for low-income populations. So on the contrary, it is a widely distributed problem. So I think these kinds of protocols or these kind of quality improvement measures are applicable to any context. Obviously, they should be adapted to the socio-demographic context because we have different conditions. But I think that we highly recommend implementing these protocols, especially in low-income populations. But it is applicable to any context. It is a relatively simple strategy that doesn't require any sophisticated intervention, rather than education and teamwork. And this is, in most cases, is enough for producing a profound impact on medical and hospital outcomes. So we highly recommend to implement these kind of protocols.
Well, thank you both for joining. We'll make sure we include a link to the article in the show notes. To check out this or other Currents content, head to currents.neurocriticalcare.org. And as a reminder, NCS offers free CME for select podcasts. Listen via the NCS Learning Center and complete a short survey to receive your credits. And don't forget to add us to your favorites.